as where's the presentation here? A minute. Yes, so the term hemovigilance has been derived by amalgamation of two words. The Greek word hema, which means blood, and a Latin word which vigil, which means watchful. So it's basically watching of blood. That's what hemovigilance means. The International Hemovigilance Network, together with the ISBT, which is the International Society of Blood Transfusion, have defined hemovigilance as a set of surveillance procedures covering the whole transfusion chain, intended to collect and assess information on unexpected or undesirable effects that result from the therapeutic use of blood products, and more important, to prevent the occurrence or recurrence. So WHO basically defines as the entire transfusion chain, but also including the follow-up of the patients and the donors, even after they have been transfused. And to some countries, this can go up to 30 years. 30 years of follow-up of the same patient or the donors after they transfuse, after they donate or they get a transfusion. Yeah? The next slide. So the goal of hemovigilance is basically a continuous quality improvement of the transfusion chain through corrective and preventive actions to improve basically the donor and the patient safety. That's the main goal, is to improve, to make sure that the patient and the donor are safe. And apart from that, is to ensure that there's no wastage of blood or the blood product. So it's basically an integral part of safety in blood transfusion. So for an effective, for us to have an effective national hemovigilance system, there needs to be in place a few things, like the national blood policy and plan that is very deliberate on hemovigilance, proper legislative and regulatory framework that defines the role of hemovigilance, a well-organized, nationally connected blood transfusion service, that goes without saying, quality systems in blood transfusion service and in hospitals, particularly the blood banks. And finally, there need to be hospital-based transfusion committees which have oversight of all aspects of clinical transfusion practice, because this is where we will get the data that feeds into the hemovigilance about the blood service in that hospital. So globally, we know that about 107 million units of blood are collected or donated yearly. Nearly 70% of these blood donations are collected in high-income countries, which constitutes about a quarter of the world's population. If you look at the donation rate, developing countries donate per thousand population per thousand people almost 10 times. So in developing countries, there's about 39 or 40 donations per thousand people in a population, as opposed to in our underdeveloped countries, where there's a donation of about 4 people per 1,000. So you can see that discrepancy in donation rates, but still important. So as per the World Health Organization, the global database on blood safety, a national hemovigilance system exists in about 42 countries of those 105 which reports. So that's about 40%. So worldwide, there are about 1 of 5 countries that reports routinely to the World Bank on hemovigilance activities. Out of those, 42 have a proper national hemovigilance system, with about 24 countries which are still processing or developing the systems on hemovigilance.
We have lost the slides. We are not seeing anything in the screen.
Evelyn, Dr. Evelyn. Evelyn.
Doc, pole sana. My network is poor. You're on which
Yes,
slide?
I'm on slide 7.
Okay, are we there now?
We are not seeing anything, yeah?
Oh no.
They're just seeing you.
I'm so sorry, Daktari. These challenges are very technical.
It's also my change on my side also, eh? So we are still learning on these things. Yes, thank you. Now we are seeing that. Eh? Okay. So just to repeat, I'm just saying that as by the WHO Global Database on blood safety, a national hemovigilance system is present in about 42 countries of the 105 that are reporting. Eh? So 105 are reporting, but those ones who have a proper national hemovigilance system is about 42. With about 24 still developing them. I'm hoping that Kenya is one of those countries within the 24. Eh? But as you can see, only about 14% of developing and transitional countries have transfusion committees. Eh? So in developing countries, the next slide, in developing countries, there's general lack of awareness and proper training about the management of transfusion-related adverse reactions among health workers. And this leads to underreporting of transfusion errors. And I think this is the purpose of such initiatives by KNBTTS to ensure that most of us are aware and properly trained so that we're able to identify and report any transfusion errors. Many African countries do not have an effective hemovigilance system, and very few data regarding transfusion incidents in Africa are available. Eh? So there is also lack of standardized and effective hemovigilance system that also affects the reporting. And because the reporting is also not mandatory, nobody is forced to report. But if there's a system that ensures that we must report any adverse reaction with consequences, then hopefully that can be implemented and it can work in a situation like ours. So what are the requirements? Next slide. The requirements of an effective hemovigilance. The most important thing that there should be a full traceability of blood products from the donor to the recipient. That's very important. That once the blood is donated from a donor, that blood goes to the recipient. It's able to be traced backwards. That patient can be told that the person who donated blood was XYZ, and he donated blood in this place. This is infectious state, and this is basically that's the records pertaining to this blood unit that you've received. And also the notification of adverse events, very important. So full traceability and notification. So if there's an hemovigilance system without a notification of adverse events, then it's not working. If there's adverse events being reported, but you can't trace, then still it's not working. Yeah? So you require those for a hemovigilance system to work effectively. Next slide. So traceability basically describes the ability to reliably follow the information trailed from the donor to the recipient and vice versa in a timely manner. It's essential to ensure the ability to recall at-risk products. So once you have traceability, you're able to recall products that you've released to the hospitals, which have some form of risk. You can say these units that were released to the hospitals are not safe. Please return them. Don't give them to the patients. Eh? Also, to identify recipients of non-conforming products. And finally, to also fully investigate these adverse events. Eh? So traceability helps us ensure that this system is done well, also together with the reporting of the adverse events. Eh? So the next slide, I will just touch briefly on what it is that we are reporting. is basically transfusion reactions. This has already been covered in, I think, the previous speakers, so I will not repeat, but just to mention for purpose of revision and for those who are not there last time. So according to the time of occurrence, we divide the adverse reaction to acute or delayed. So any reaction that occurs within 24 hours after commencing a transfusion is referred as to acute, while any that occurs after 24 hours, Dr. we are in slide number 11, slide number 11, number 11, 11, before that, just go up. This is slide number 11, Dr. 11, yes. So just describing transfusion reactions because this is what we are reporting. So any that occurs within 24 hours is acute, any that occurs after 24 hours is delayed. Also, we classify reactions depending on their pathogenesis. So divided to either infectious or non-infectious adverse reactions. So you have acute, infectious, acute, non-infectious or immunological, or delayed infectious or delayed non-infectious. So next slide. The next slide. So the major acute reactions, just to mention them, you have the acute hemolytic transfusion reaction, which occurs within 24 hours. You have the febrile non-hemolytic transfusion reaction. You have the allergic reactions, including anaphylactic reaction. You have the transfusion-associated acute lung injury. You have the transfusion-associated circulatory overload, hyperkalemia, and the infectious one, which is bacterial infections. So these are all occur within 24 hours on commencement of blood transfusion. The delayed ones, next slide. Next slide. Delayed include again delayed hemolytic transfusion reaction, delayed serological transfusion reactions, post-transfusion purpura, transfusion-associated graft versus host disease, hemosiderosis, and viral infections, viral and parasitic, including hepatitis B, hepatitis C, HIV, other viruses, malaria, all those are part of the delayed reactions. And you can see some of these can take longer than 24 hours. They can go up to many years even after somebody gets a transfusion. So it's important to know that the cutoff of following up someone within the way it's defined in the WHO or with the European countries about 30 years after someone receives a transfusion. Next slide. So this concept of near miss, which most people do not report, and is very important, especially when you look at when we are trying to look at the quality or how good is our system, how good is our Hemovigilance system, or how good is our blood service. It's something we call the near miss. So a near miss is an episode that represents a flaw or deviation from the standard procedures that is detected before the outset of the transfusion that could have led into improper transfusion or a reaction or a recipient. So this is something which tells us that maybe our SOPs or our procedures or the people who are handling our blood are not well trained. So that's why it's important to mention even these things that do not cause actual harm, but to mention them as part of making sure the system is basically made more effective. Next slide.
4 minutes, Dr.
Yes, I'm almost finishing. Yeah, next slide. So just brief, Hemovigilance, there's something else about the donors. We forget about this. When you talk about Hemovigilance, it's not only about the recipients. It's also the donors, the people who are giving the blood. But in adverse reactions in blood donors, we call it a complication since the etiology is normally different. The adverse reactions in donors could be due to the donation process, selection of the wrong selection, or management of the blood donors. Yeah? They're not managed properly. Yeah? Next slide. And these reactions can be either local reactions, including needle insertion, vessel injuries, nerve injuries, and general reactions like vasovagal, immediate or delayed, or even bleeding. Yeah? And it's important to document all this because it also shows us where we need to do more training or where do we need to do more emphasis. Eh? So where is the hemovigilance done? Hemovigilance should be taken at the hospital level. That's the main place, especially by the hospital transfusion committees. And then this is reported upwards to the NBTS, to the RBTCs, satellite RBTCs, going upwards to national level, and even beyond the national level to the international level, so that we comply with the WHO requirement that we report our hemovigilance on our adverse events in the world arena. So who can report? Anybody, any healthcare professionals involved with blood components in administration, handling, monitoring, ordering, or delivery. Anybody, you can report that there's something that's going wrong, the blood has been stored for long, or it's not been handled properly. That needs to be reported. Yeah? Next slide. So who can use the data again? It may be used locally by the hospitals, HTCs, that's the hospital transfusion committees, and the safety and quality staff. But beyond that, NBTS will provide summary reports to the participating hospitals on their performance so they can improve their systems or contribute to national and international hemovigilance reporting. Yeah? So in conclusion, hemovigilance program is essentially a continuous quality assurance program that ensures the safety of our patients and our donors. And beyond that, it ensures that there's optimal use of this scarce resource that we call blood. Eh? Thank you.
Thank you very much, Dr. You remain with 11 seconds, and that was very commendable. So I want to kindly request that maybe if in case of any comments and questions, we shall have at the end of this presentation as 20 minutes to ask questions and maybe to make comments. So let's keep our questions and then we shall ask after the whole presentation. Otherwise, now I want to welcome Mr. Hilary Barmasai to do his presentation. Barmasai, are you ready? Hilary. Hello, Mr. Barmasai, are you hearing me? Can you unmute Barmasai? Barmasai, we are not hearing anything.
Hello.
Yes, we are hearing. You have 20 minutes from now. Welcome.
Good afternoon, everyone. My name is Barmasai Hilary from the Kenya National Blood Transfusion Tissue and Human Organ Transplant Service. Today, I'm privileged and humbled to be with a team of experts and consultants in hemovigilance And I want to thank my Dr. Maturi for the nice presentation he has made. So I'm going to go through some few slides to enlighten us on the status of Hemovigilance at the KNBTTS. Dr. Arias had already defined the term Hemovigilance, but it is just want to add that Hemovigilance is the umbrella of the entire blood transfusion chain. So it covers all the procedures that are done all the way from blood donation, processing, blood transfusion, and even after the patient has been discharged, there is that follow-up. Continue, please. So the rationale for Hemovigilance is that more often than not, Hemovigilance activities have been directed to the recipient, which is not ideally should not be the case because there are transfusion reaction that also happened at the donor stage. So we have three main stages where Hemovigilance plays a very key role in as far as blood transfusion services is concerned. So the first stage is the donor selection. That is how we select our blood donors. We check their past medical history, we check their health risk behaviors, and then there's also a part that we are going to also indicate any adverse donor reaction. So once that selection is properly done, then we also have the phlebotomy techniques that should be applied so that we make sure that we don't harm the donor that may cause hematomas, inflammations, and such alike in the site of venipuncture. We also have donor care during donation and post-donation care. So all these will accumulate to the donor safety. And the second stage is the testing, equipment, preparation, and reagents. And in this case, when all these equipment are well calibrated, QCs are done, proper conditions for preparation of components is done, then we will achieve or will get a safe product for transfusion. Again, thereafter, now when the blood has been taken to the ward for transfusion purposes, the person who's prescribing that, the clinician, should also check the way the need for that transfusion. And then we also have the procedures for cross-matching, patient sample identification that should be done well so that at long last will not harm the recipient on the other hand. So the actual blood transfusion also should be monitored well in terms of the rate and any reaction that may happen. So, and that again will result into the recipient safety. Next. As Dr. has already said, we have two types of adverse transfusion reaction. We have the acute and we have the delayed, and that's what has been well taken care of by Dr. Maturi. Then we have categories. We have those ones which are donor related. As I said, we have hematomas, we have fainting, sweating, nausea, vomiting, and inflammation. So those ones happen where the donation is donation venue. We also have at the laboratory, we have the blood components and testing. So all those processes must be well taken care of to ensure that we get the right product with enough or sufficient therapeutic parameters. So also we have the issues of devices, and for this case we have quite a number of devices that we use in blood transfusion. For instance, we have the blood bags. So if there are leakages in our blood bags, if there are clots, then that product may not be of good quality to be transfused because it will lead to adverse transfusion reactions. Now on the recipient side, this is the one that has been more of many a times being taken care of, and that This one happens at a ward where the patient is receiving blood. Next. So we have, that is just a step to show us the post-donation adverse reactions that has been reported in our blood establishments around the country. When I say blood transfusion establishments, I mean the blood banks and our satellites whose main mandate is blood collection, screening, and dispatch to the user facilities. So as we can see, there are reports on fainting, hematomas, vomiting. All these have to be captured so that in case there are measures to be undertaken, then should be put in place immediately to avoid or prevent or control some more from occurring. Thank you. Next. Now, what is the role of hemovigilance? One, first is identification of adverse events. And for that case, these events, as I said, occur all the way from the donation site. So we have the donor clinic where these patients donors are bled. These are critical area that we identify these adverse reactions. We have the laboratory and the ward where the patient is receiving blood. We also have documentation and reporting. And for that case, we have quite a number of tools, as I will show in the subsequent slides, for documentation and reporting of adverse donor reactions. And this information will be channeled to the HTCs and all the way to the Kenya National Blood Transfusion Service National Office, which will liaise with the national regulator, the Pharmacy and Poison Board, and then they will give the feedback after the investigation has been done and analysis. Next. Continue. Next slide. Is anybody hearing me? Rotich? Good. Now we have the issue of adverse event reporting system. And in the case there is an, sorry, maybe you can go back. The previous slide, please. Okay, thank you. Now, on the adverse event reporting, in the case, I think I had explained this well, but this is the flowchart that shows what happens when there is an adverse reaction one at the RPTC or satellite, that's the blood establishment, and that when there is that information is channeled to the KNBTTS monitoring and evaluation, which should go all the way to the National Hemovigilance Technical Working Group for analysis, investigations to be done, and feedback mechanism back to the facilities. Also from the blood transfusion facilities, where we have HTCs, in case of any donor reaction, then that report should go direct to the NRA, whereas simultaneously should go to the M&E of KNBTTS for further action. Next. Next, please. Now, concerning the hemovigilance tools, we have quite a number of tools, and wish to inform you that currently we are reviewing and updating our hemovigilance manuals and tools, among other tools that we use in KNBTTS. And in this case, I would wish to inform you that we have around 8 of them. So the first one that we use to collect information and more so on hemovigilance is our blood donor questionnaire, which basically is filled by the donor before donating blood, but it contains the demographics of the donor and also the health history of the donor, and also it captures the information on donor adverse reaction. So that is the first stage at which we monitor. These are one of the critical control points that we check to make sure that the process is going on. Well, we have the clinic laboratory register. This one is used by the in the blood establishments during blood collection. The clinic part of it is used for registration of the blood donors, and the laboratory part of it will be used to document information on grouping results and screening results. This is the tool that will be used in case of any reaction. We will trace back to this register. And also in screening, if there are many units, if the rate is high on screening, it's also indicate that maybe there is something wrong in donor selection, and so the information should go back to blood selection criteria to solve the problem. We have the component register. This is the register that we document all the blood components that are prepared. Remember, we have about 5 of them. We have the packed red cells, we have the platelets, precipitate, fresh frozen plasma, 24-hour plasma. We also have a ferritic platelets. So all this will be captured in this document, the quantities, the expiries, and the person who was doing the same. We have the blood requisition form. This is one of the documents that is used by the clinicians when requesting blood from the blood transfusion unit. So it has the name of the clinician requesting, the type of blood component that is being requested, the amount or the number of units that is required. So we also have the blood request issue forger. This is the form that is used by the blood transfusion unit to request the blood from a blood establishment, that is the blood banks or satellites. And this is used mainly for accountability purposes and traceability of that blood unit. We also have the lab cross-match register, and this one is the blood transfusion unit to document all the cross-matches that were done, the requested ones, the ones that were done, and the person who was doing the cross-match. Next. We also have the cross-match compatibility form. This is the form that is attached to the unit once it has been cross-matched to accompany the unit to the ward. So it has the patient details and the unit number, the person who was doing cross-match and when the cross-match was done. So once the unit has been taken to the ward, it has to be recorded in the ward register, the person who was collecting the nurse, the number of units, and the cross-match status. Then at the ward, we have the blood transfusion observation chart. This is the document that we use to monitor the transfusion progress. And so all the information is recorded in this form from the 0 minutes, 15 minutes, 30 minutes, 1.5 hours, until the end of the transfusion. We also have adverse reaction form. So in case of any adverse reaction, this is the document that is used to document the same. And this is filled by the clinician or the person who was observing, monitoring the patient. We also have the Hemovigilance monthly reporting tool, and this is filled at the transfusing facilities. This will give the information on the transfusion activities that were done during the month in terms of the requests of blood that were made, the amount of blood that was received, any screening that was done from the KNBTTS and maybe the facility. And this also is very important tool in that we will get to know if the demands are being met. You also check that all units have undergone the required quality measures so that we don't have units from wherever that they have not been ascertained fit to be transfused. Next. Next slide. Now we have
you have 5 minutes, Barmasai.
Thank you. We have the cold chain management. This is also one of the areas that is very important for our products because most of our products have different conditions for collection, transportation, and storage. So all the way from blood donation, blood bank, testing component, blood transfusion unit, and even at the ward, we have different conditions. Like for example, during storage for platelets, it should be at 22 degrees centigrade and it should be agitated, and expiry should be around 5 days. So cold chain plays a very vital role in that. If this is not properly done, then we are likely not to achieve our expected results in transfusion because of that therapeutic parameters that we need to achieve in that unit. So so what has been done the letter has been drafted to the DG, Director General of Health, and to all transfusion facilities, one, for registration purposes, so that we can have a database of all transfusion facilities in our country for easy management, and that currently we have less than 200 registered transfusion facilities out of over 800 facilities. So there's still a gap in registration. We also had another letter reference, that one that's shown there, on compliance of reporting, and that it's only less than 20 facilities that have reported on the same. So this is still a big challenge. Initially, there was a system in the Ministry of Health, the THIS2, and from the reports, for instance, July to September 2021, the reporting rate was just 1.7, so which is very low. And as we've seen, it is very important that we get these reports for planning purposes. Again, we have the PMIs, which is work in progress. User acceptance testing has been done, and piloting will be done next week, and it will be rolled in all countries, and we'll get a real-time reporting on all activities in our facilities. Next. So we have the hospital transfusion committees, also referred to as facility transfusion committees or blood management committees. They are responsible for ensuring safe transfusion practices, and it is mandatory that all transfusion facilities should have an HTC for monitoring of blood usage and also management of adverse reactions. So next. So one of the roles of HTC is implementation of the national guidelines within the transfusion facility. As I've said, we've reviewed most of these guidelines. So it is the role of HTC to ensure that they implement and also implement the appropriate use of blood and blood products. So one of the main role of HTC is also to monitor, report, and investigate transfusion adverse reactions and any near miss, and develop strategies for prevention, reduction, and improvement. They also do some cycle of clinical audits and also disseminate the information to the facilities from the results. Thank you. Now, setting up of HTC, there should be a chair who could be the head of the institution or is designee, and also a secretary for the operational purposes. And that members may be co-opted from time to time to address specific upcoming matters that may need some expertise. And the meetings should be arranged so that they are done regularly, maybe quarterly or whichever time that is convenient to the organization. And then
you have 1 minute,
they should also have the reporting lines within the organization. And next. So this is a typical membership of HTC. We should have management, maybe the medical superintendent on the hub. We should have the representative from major providers of blood, that is surgery, medical hematology, nursing department, laboratory department, and records department. So this is the typical one, but in the instance that the hospital do not have all these departments, then it will have to pick from the departments that exist within the organization. Next. So this is the structure of the HTC. We have the top management, maybe the medical sup. We have the HTC chair, secretary, hemovigilance officers if there are more than one. Then we have the members and any other subcommittee which is relevant to blood. Thank you. Next.
Your time is up, Barmasai.
Yeah, so just this, I think this is almost the last slide. So just give me some 2 minutes for this slide. So challenges facing the Hemovigilance. We have our main challenge of setting up HTCs, and also we have a problem of sustaining. This has been a challenge in many of our facilities, and as at now, we only have some few high volume facilities that still have active Hemovigilance officers. So, and let's go to the next one. So thank you. I'm going to the next slide, the next presentation, which are 4 slides on another element of interim measures intra-COVID-19 during blood donation. So kindly share.
Barmasai.
Dr. Evelyn Kamash, good, thank you.
Barmasai.
I can see it. So let me just
Excuse
share
Barmasai.
some. Yes, let me
How
share
many
some
minutes?
tools.
Excuse me, Barmasai.
Yes.
How many minutes do you need? Because your time is up.
5 minutes only.
I'll give you 3 minutes.
Thank you, sir. So these are some of the measures. We are all aware that we are going through a pandemic of COVID-19, and these are really affected most of our activities in as far as blood transfusion services are concerned. Kindly go to the next slide. And that KNBTTS is taking steps to assess, plan, and respond appropriately and proportionately to the COVID-19, and as informed by the authorized agencies like the Ministry of Health and other relevant sources. So, and that all blood donor activities are aligned to the protocols of COVID-19 that has been set by the Ministry of Health, so that we take care of the staff who are attending to our donors, and also make sure that we take care of our donors. So there is a strict adherence to the IPC procedures as directed by the KNBTTS management. Next. Next, please. So what is the intra-COVID-19 donor eligibility criteria? So these are some of the issues that have been put by the KNBTTS to make sure that we safeguard, especially the blood components that we receive from our donors. So one of the eligibility criteria is that potential donors who are willing to donate blood should be educated so that they can self-divert themselves based on the risk factors for COVID-19 if they are feeling unwell or they have direct exposure to COVID-19 from a confirmed case for at least 28 hours. So those ones should not be allowed to donate blood. Also, donors who fully recovered from confirmed COVID-19 should be allowed to donate blood after 28 days. Again, those potential donors who've been vaccinated with live attenuated COVID-19 vaccine, or those ones who do not know what type of COVID vaccine were given, should be deferred for 2 weeks. And those persons who feel unwell after receiving the vaccine should be deferred for 1 week after complete resolution of the symptoms or specified that the receipt of the virus factor based or the live attenuated vaccine, whichever is the longest period. Maybe the next slide, Atari. So as we go to the next slide, these were good. So persons participating in clinical trials, we understand that research is now ongoing for this COVID-19. And so those persons who are participating in clinical trials of a live vaccine virus should be deferred for 1 year after receipt of that experimental vaccine, and that those ones who received non-live vaccine should be deferred for 28 days. I assume that you all understand that the difference between the live virus and the non-live one, and the impact, especially in as far as our immunity is concerned. So I'm not seeing the last part of it. Good. And then for vaccines that require more than one vaccination, kindly each vaccination should be regarded as independent, so that for the purposes of blood donor deferral. So thank you for listening, and back to you, Mr. Rodich.
Okay, thank you, Barmasai, for that presentation. I had to add you some few minutes in the last slides because that presentation was very new, and I saw it was very important for the team, all the team members. So for now, we are going to go to our discussant, who are Dr. Valentine, Dr. Dave Paresh, and Eric Tangala. So we shall start with Dr. Valentine. Maybe Dr. will give us her experience on advanced reactions that maybe she has encountered, and maybe give us some examples. So I want to kindly request Dr. Valentine. We are going to give you 10 minutes to do your presentation. Welcome, Dr.
Thank you very much, Thomas. As I go forward, I think I note that part of what was documented or sent to us is maybe to also give reactions to the presentation. Is that covered? Am I also supposed to do that, or just stick to the adverse reactions with examples? Thomas.
You can do the both.
Both. Okay, thank you. So in terms of, maybe I will start with a few reactions to the presentation that I have, that I think would then be followed by discussions from other participants. I think generally I appreciate the presentations, which are very comprehensive and enlightening. I also appreciate the COVID guidelines, which interestingly, I think they are under development. And as we all know, COVID is fairly new in our setup, and there is still quite some confusion about when do you donate after vaccination, after having COVID. And I think once those are released to the general public, they are going to be very helpful for the facilities and for especially the ones who are receiving donations. Maybe something which I would like Mr. Barmasai to clarify is whether they are testing for COVID in the donated blood, knowing that some of the donors may be asymptomatic, and can COVID be transmitted in transfusion, during transfusion? Maybe, and I know that typically COVID is not one of the ones which are tested for, but I don't know whether the National Blood Transfusion National Blood Transfusion Services, I know now your name includes organ donation services, has considered or thought of that. The other thing which I found very interesting is the fact that adverse reactions include reaction by the donors, which I think usually we think about donor reaction from the recipient, but donor reactions, I had actually never thought of that by myself. Maybe as a background, basically to where I'm working from, I am a general surgeon. However, I work in the Blood Transfusion Committee and work together with our laboratory for some quality assurance and improvement issues. So that being said, in terms of my reaction to the presentation, then I will now go forward to my experience with the adverse reactions. In terms of adverse reactions, I'll talk about maybe a couple of adverse reactions that I have encountered during my training and also at the hospital where I work. I think one adverse reaction that I remember happened is a case of transfusion-associated lung injury. And this was a patient who came in and needed blood because of trauma. And after the blood transfusion reaction, within about 24 hours, started developing respiratory complications. And after the respiratory complications, investigations, including chest X-ray, showed a picture that looked similar to what now would be transfusion-associated lung injury, which basically looks like, what is this? Patchy, fluffy infiltrates bilaterally in both lung fields. And that was very interesting to me because many times we think about the blood transfusion reactions as the allergic reactions, the hypersensitivity reactions, and so forth. And it was very interesting that this was likely attributed to, at least in our assessment, to a transfusion-associated lung injury because we did not find anything else that we could attribute the new respiratory complications to. We could not attribute them to trauma. The second adverse reaction that I saw, and also this is where I trained, was an interesting one of actually Ebo Incompatibility. And this was a big issue where I trained. So we had a patient who had undergone cardiac surgery and was losing blood and required reoperation because of some active blood loss. So we required urgent blood and his blood group was not available at the moment, at that time. And so we were able to get some blood from a facility, but in a different facility. But interestingly, this blood group was mislabeled and was labeled as O positive, and yet it was B positive. Because of the urgency of the blood being needed, the blood was given to the patient as type specific because of the urgency of the blood as the lab continued with the cross match. As you would imagine, the blood was transfused rapidly. And by the time the lab called us to say that it had failed cross match and they discovered that the blood group was different, all the blood was in the patient, which was really a big issue because this patient went on to have, of course, an Ebo Incompatibility reaction and suffered some renal injury for which thankfully he recovered from, although it took a few months for complete recovery. Thankfully, he even did not require dialysis. His kidneys shut down for a few days and then they came back slowly. So we had even referred him for dialysis, but his kidneys picked up before he received dialysis. So that is the second example of blood transfusion reaction. The third one that I remember in terms of from a patient is, which is really common, just the fevers and chills that are common. And usually I think the nurses manage those, the minor blood transfusion reaction, they manage them just with slowing down the rate and giving paracetamol. And if they persist is when they stop the reaction. I think I have seen one that we had to stop a reaction. We had to stop the transfusion, and that one the patient developed the chills, rigors, slightly low blood pressures, but were managed with the fluids and resuscitation with fluids and giving of chlorpheniramine, that is Piriton and hydrocortisone, and the patient generally did well. So I think those, in terms of examples, I think I mentioned the first one was what we suspected to be TRALI. The second one was an Ebo Incompatibility reaction. And the third one was what we thought was a hypersensitivity reaction, where it was confirmed that the right blood groups and was given to the patient with the correct cross-match having been done. I don't know whether I've exhausted my 10 minutes, but that is all that I have.
Thank you very much, Daktari. You have managed to donate for us 2 minutes and 48 seconds. So,
Okay, thank you.
Okay, thank you very much. I think those life experience is teaching us a lot, especially whereby now you did give a B. A patient was given B positive instead of O positive. And,
positive, yeah.
Yeah, it happens sometimes. So now I want to welcome Dr. Dev Paresh to share. I know his expertise in transfusion. He has been in the transfusion business for a very long time. So maybe I want to welcome Dr. to share with us his experience. Welcome, Dr.
Thank you very much, Mr. Rotich. And I want to thank the two presenters, my colleague, Dr. Maturi, and the second speaker for an excellent presentation, very comprehensive, very appropriate. I have been a hematologist for a number of years, and I've also been in charge of the laboratories where I've been working. So both laboratory and clinical hematology. So there are all these challenges that we face. I'll start off with the donors, since it's a continuous spectrum from donor to recipient. We do have challenges with donors. Fainting is quite frequent in some of the donors, especially first-time donors. The second major problem we face is hematomas and large bruises, which can be very alarming to the donors, and which tends to be self-limiting, and it tends to disappear over a period of time. Most of this hematomas and bruises can be technical. Either the needle is removed while the pressure on the cuff is still maintained, or these are patients who may, or these are donors who may be on blood thinners. So it's important to identify them earlier on, and if they are on blood thinners, you may need to apply pressure for a longer time. Fainting is just handled in the usual manner that we do for other patients. Keep them on the bed, raise their legs, and within 15 to 20 minutes, they seem to be okay. We just give them enough fluids. The other place where we have problems again with donors is when we don't have vascular access, and many of these donors are deferred, and it does become a problem, especially if you are looking for people, for donors who have the rare blood groups or who have rhesus negative blood group, and it can be quite frustrating. So those are some of the donor issues that I've come across during my practice. Now, coming to recipient issues, there are quite a number. The most common one that I have come across is the febrile reactions that have been mentioned by the previous speaker. And yes, this can be quite cumbersome and troublesome. And some of them can be so severe that you think that it's a major transfusion reaction and we have to stop the transfusion. Fortunately, most of these reactions occur towards the end of the transfusion, unlike the major transfusion reactions which occur as soon as you start the transfusion. So nonetheless, sometimes there is quite a bit of wastage which occurs. And what I tend to do is that if these are patients who develop a febrile transfusion reaction, especially those who have been having previous blood transfusions, multiparous women and so forth, I pre-medicate them with hydrocortisone and paffaralgan, that's intravenous paracetamol, before the transfusion. At least allow about 15 minutes to half an hour. And in those who have very severe reactions, you can use leukocyte filters. Major transfusion reactions have only come about once or twice that I've come across them, and that's because of clerical errors, as mentioned earlier on. The area of major concern for me in my practice has been the viral infections. I have had one patient who developed hepatitis B, and there is another patient who even developed HIV infection, and it can be quite a nightmare to handle this situation. It's important here to have a look back system. You know, traceability is one of the most key features in hemovigilance. So you must be able to trace back your donors and have them rechecked. Unfortunately, some of them cannot be traced or are difficult to trace, and that can become a problem because of medical legal issues that arise from transfusion transmitted infections. Malaria also can be quite a problem, especially multiple transfusions, large volume transfusions. In exchange transfusions as well, some patients have developed malaria. Surprisingly, very high parasitemia, but not much apart from high fevers, but no serious sequelae to this to the malaria that they acquire through transfusions. Then the other problems I have with my patients is, and which was mentioned by Dr. Maturi in his adverse reactions, the late reactions, is hemochromatosis, iron overload. And I tend to monitor the iron levels over a period of time, and we start iron chelation early so that we prevent the complications of iron overload. So these are some of the issues that I have come across in my practice. I just wanted to ask about our presenters. How do you document near misses? That was something that I wanted some information on. And the second part where I would like the presenters to highlight or to emphasize or to bring forth some information is when we have shortage of blood, and if there is a delay in transfusing because of shortage of blood, or not able to get enough donors, or not getting suitable donors, how would we handle that situation? I think that's what I can contribute at the moment. Thank you.
Thank you very much, Dr. Dev. Yeah, we really appreciate your presentation. And at the end of the question time, I'm very sure your 2 questions will be slotted and they will be answered. Otherwise, thank you for giving us some 3 minutes. So I'm going now to go directly to Mr. Eric Tangala, who is a laboratory expert in hematology. So I'm going to kindly request him if he can discuss about with us about the laboratory side of Hemovigilance. Thank you. Welcome, Eric.
Thank you very much, Thomas, and thank you all the previous presenters, Dr. Maturi, Barmasai, Valentine, and Dr. Dave, for quite an informative session. So what I will do, I think I wanted to concentrate a little bit more on policy, on issues of guidance, where we are going as a country, and the relationship between blood safety and even other upcoming policies, because it's one thing, it's a professional and also a legal obligation for all transfusing facilities actually to report through the national system. There is nothing like an exemption. All of us should be able to report through the national system to inform policy and also guidelines, and also for safety issues. So all transfusing facilities actually have an obligation, and transfusing professionals. The other thing that I wanted to comment on also is the issue of tools. I'm actually very happy that finally we have the compatibility forms, the cross-match compatibility forms that actually accompany the blood. This is one of the tools that really go a long way in helping us to be able to identify the units. And Dr. Valentine has talked about a unit that was given which had been mislabeled and all that. So some of these tools are very key in actually helping us to be able to document appropriately and follow through when it comes to the transfusion process. The other thing I wanted to comment on is that the transfusion indicator for transfusion safety is actually part of the patient and healthcare worker safety quality of care framework. So it's not like we are going to be choosing whether we want to report or not to report, because it's part of the national framework. So blood transfusion safety is an indicator. So all facilities will have actually to be able to report and actually show evidence that they are actually complying with the guidelines and blood safety protocols that have been put forth by the government through KNBTS. The other thing that I wanted also to comment on is there's actually a component of blood transfusion safety in the Kenya quality model of health. So it's actually going across just a facility, and it's a national framework. So we really have an obligation to be able to report. I know at times there's been that battle of my facility is actually collecting on its own. Why should I report to the national framework? It's actually mandatory for us all to report through the national framework because at the end of the day, that is where we normally get information, even on policy review and policy development. So for me, my comments are just around that all the policies, even when it comes to the regulator and issues on certification, one of the items that comes out very prominently is actually the issue of hemovigilance. Is the facility capturing matters around blood safety? Are they able to report their indicators even through the national framework? So even the facilities that are actually in the process of looking for certification, accreditation, applying for even licenses, this one is becoming quite an issue that has to be taken up by all the facilities. So for mine is to encourage everybody on this call. I'm seeing we have quite a number, more than 500 people. I'm sure people are here from both private, public, and even mission hospitals, that the system is there, the system is working, and we all need to report to make sure that all these indicators are actually being captured and they are informing policy when it comes to policy development. So that is what I needed to comment on. So thank you very much, Thomas, and thank you other discussants and the main presenter. Back to you, Thomas.
Thank you very much, Juan Eric. We really appreciate all our panelists. So for now, I would like us to go maybe for it's a question time, and there is already some our participants who have already asked some questions. So I'm going to read, and maybe any one of us can answer. So the first question is from Alex Orire, a lab manager, Kiembu Sub-County. He's asking, once a patient has been transfused and discharged from the hospital ward, how often should we check for possible delayed transfusion reaction? Many a times it is assumed all is well. So any of us can answer that? Maybe Dr. Maturi? Or...
Yeah, I can answer that. So after someone has been discharged from hospital, the first time you check this person is ideally after 72 hours. You come back for just a routine check. And then after that, the next 2 weeks after that, because in 2 weeks, we are expecting what we call one of the delayed graft versus host disease, especially if there are patients who are immunosuppressed. We'd ask them to come after 2 weeks. Then that is basically it. After that is self-reporting on any symptoms that they have. But those are the two crucial times: 72 hours after they have been discharged from hospital, and then 2 weeks after they are discharged. So those are the two times that you can do a follow-up. Then there's a question on someone who was asking about COVID. COVID transmission. I think somebody asked about that. Yeah, so far, we do not know any case of anyone who has been infected with COVID, especially from asymptomatic patients. I have just seen an article that was released by ISBT recently, which was talking about a patient who had aplastic anemia, who was transfused apheresis platelets with a person who had COVID actually, who had COVID within the next 24 hours, but this person did not suffer from COVID. So there's no evidence that you can get COVID through blood, especially from asymptomatic patients. So I think those are the other questions that the near about someone asked, Dr. Davi asked about the near misses. How are they recorded? I think this is a gap in our recording tools, and this is something that NBTS by Masai maybe can answer, but can be picked up so that the near misses can also be recorded as part of the Hemovigilance system. Yeah, I was quite happy when I listened to Dr. Valentine on that when she described about TRALI. TRALI is rarely, people don't really recognize it. One time we wanted to do a study of advanced reactions in Kenyatta targeting TRALI. And surprisingly, we just did not get. We went back the records for over 10 years and we did not get any case, which of course is not true, because we know that the incidence of TRALI in developing countries is about 1 to 5,000. If you take that to Kenya, it will be much higher because our products are not reduced. We do not irradiate our products. So we expect us to have a high incidence of TRALI. If you talk about Kenya, we transfuse about 400,000 units. So minimum, we should have at least 100 cases of TRALI in the country reported. Or if Kenyatta, we transfuse about 3,000 units in a year. So you get about 6 or 1 case in every 2 months. So it's interesting that Valentine, you were able to pick that. It shows that your Hemovigilance system or your committee is very top notch. So that is quite interesting. I don't know. I think I've answered the questions that had been raised.
Thank you, Dr. I'm seeing time is not on my side. So maybe I will ask Dr. Evelyn, maybe if she can give us more time for some questions, but if not possible, then Dr. Evelyn.
I think we can do an extra 5 minutes, maybe take 2 more questions.
Okay, thank you, Dr. So I'll go to our next person who asked that question. Good afternoon. My question is whether there is a standard of reporting forms and whether there is sensitization on how to report to the healthcare workers for us from West Pokot. Parmasai can answer that quickly.
Thank you very much, Boaz, for your good question. I want to state that currently we are reviewing all our reporting tools. So yes, we have the tools, we have the forms, and we'll be disseminating to all counties in due course. And also, there's a question on any guidelines from KNBTTS on regular donor management as other countries use iron supplements. And again, on so all these documents are being reviewed and they will be disseminated soon. Thank you.
Thank you, Parmasai. I had seen a question about hepatitis. I don't know whether I'm missing it. I don't know if anybody can find it. Somebody has asked about hepatitis vaccination. I felt
Been
maybe
answered.
Oh, it has been answered. Okay, thank you. So another question is, any guidelines from KNBTS on regular donor management as other countries use iron supplement? I think it has been answered again by Barmasai. So Okay, there is an anonymous question. I want to know more about volume expanders that are in use. Alex, we had asked, we had answered your question so kindly. Maybe I can go for another question. Talk about golden blood group. Maybe any of our team members can answer. Eric?
He's asking about golden blood group.
Yeah, but I don't think there is.
Okay, that one, unless I can push it up to somebody else.
Maybe she meant he or she meant universal, universal blood group, then you can give to anybody. Maybe that's what she meant.
And unless that is what she means, because I've not heard of golden blood group. But yes, of course, there are issues around the universal donors and universal recipients, though we try our best not to go by that blindly, because again, we have to do the titers of, if it is blood group O, we have to do the titers of anti-A and anti-B just to make sure that they are low, because again, we also have the dangerous universal donors who have very high titers of anti-A and anti-B that again will cause a transfusion reaction. However, the universal donor again is O and universal recipient AB. However, with caution, and I know Dr. Maturi, that's your area, you would like probably to chime in and just re-emphasize on the issues of those very high titers of anti-A and anti-B.
No, I think you've just mentioned it very well. There's no, I mean, what I would just advise is you don't want to use a typical blood transfusion when you have no option. Otherwise, it's important to give group-specific blood. NBTS is now providing enough blood, so I don't think there should be now an issue of where we give blood that's not group-specific. Because there's even if the risk is 1%, it's still a risk. Yeah, we want to give the best quality to our patients, so we avoid that unless it's life and death issue where you have no option.
Through the chair, Mr. Rotich.
Yes, Barmasai.
Yeah, let me just also put an input on the RESAs, on the golden blood group that this refers to the RESAs null blood groups that contain no RESAs antigen in their protein, and it's actually the rarest blood group in the world. And I think from my research, less than 50 individuals are having this blood group. So it is one of the rarest. And thank you for that.
Okay, thank you, Barmasai. So may I take this opportunity to thank all the participants, and we are very grateful. We have had a very wonderful day. So I have been your moderator, Thomas Rotich, head RBTC Eldoret. I don't know, Barmasai, close with us with a very short prayer.
Thank you very much. So again, allow me just to say thank you very much all the participants, and I wish also to thank the leadership of the KNBTTS led by Dr. Ndogo Kalonzo for allowing us also to participate in this progress. Let me now go and pray. Let's pray. Our Father who is in heaven, we come before you this time with thanksgiving for what we've deliberated upon. We pray that may this discussion be helpful to all of us for the benefit of our patients. Even as we disperse now, may you take care of us until we meet next time. For I pray this short prayer, trusting and believing in the name of Jesus Christ. Amen.
Goodbye. Thank you.
Bye. Thank you.
Thank you.
Bye. Thank you. Join us on Friday morning.